I'm just going to ask some questions of our two speakers and let them answer and explain these issues to you. And then when we're done, we'll go right into the question and answer period. Okay? So one of the things that has really changed dramatically in the last 21 years in myeloma is that now people need to have an understanding of genetics and chromosomes and things like that, which you didn't need to know about myeloma 20 years ago, but now you do. And one of the things that the myeloma crowd that we want to get across to people is that you really must understand what your individual chromosomal issues are and understand why that's important. So I'll start out with the first question for our doctors, and you can just pass the mic between you. In terms of chromosomal abnormalities, why should patients know what their chromosomal signature is, so to speak, and why does it matter?
I'm holding the mic, so I'm starting. When we talk about the chromosomal abnormalities in the plasma cell, it's important to make a distinction. We're not talking about heredity. We're not talking about a trait that is being passed on to subsequent generations. All cancers are genetically unstable, and over time, the DNA in the cancer cell mutates, chromosomes break, duplicate, pieces move around, and that's true of multiple myeloma as well, that this non-hereditary cancer has the same gene instability, and there are really scores of abnormalities that can be found, but by simple observation, why the chromosomal abnormalities lead to the outcomes that they do is not very clear for most. But there are some genetic abnormalities that we just look at the genetic abnormality in 100 people, that genetic abnormality will be associated with either a similar outcome or an inferior outcome to 100 people without the genetic abnormality. So you know it predicts for a poorer outcome. And in terms of what does it mean in Europe, the presence of a higher risk genetic abnormality is used as a decision tree of whether you get 2 transplants or 1 transplant. In the United States, at some centers, it may determine the type of maintenance treatment that you receive. There are clinical trials actually that are now developed that target specific genetic abnormalities. There are antibodies now that are used against some genetic abnormalities. There has been a trial of a pill that's been used for a very specific genetic abnormality. And so the 3 issues are impact on prognosis, impact on maintenance, decisions on transplant, potentially, as well as the development of targeted therapies for those genetic abnormalities. No, I didn't talk about any medications.
No, this summarizes it very well. I think the issue of how we look at prognosis and look at chromosomes has shifted a little over the years, with some things being thought to be bad and not, known to be now known not to be as bad as they were. I think that we rely heavily upon chromosomes to predict prognosis, at least at the beginning of the disease. So we rely heavily upon what are those genetic abnormalities. And in large groups, it looks like they do predict fairly well. Unfortunately, we know that they clearly don't predict well enough to give us what I would say is risk-adaptive therapy. So we know they're not good enough predictors to say, hey, if you've got this, you should have this therapy or you should have this different therapy. So I agree that some people look at them in that way, but there's not great data to support it, to be quite frank. And then I think the real implication potentially could be that there are new medications coming for specific chromosomal abnormalities. Again, not fully targeted. The major one that springs to mind that's probably been most studied is the drug venetoclax for the specific translocation 1114. And it looks like in people who have the 1114 translocation, that drug probably works in about 60 or so % of people. So not a definite, hey, if you've got it, it's definitely going to work, but it's somewhat predictive.
Just a general comment about prognosis. Again, when we talk about prognosis, we're really talking about large populations of patients and comparing outcomes in very large populations. But when you drill down to an individual patient, it gets a bit cloudier there. And when we say that something might have an adverse prognosis, again, that's in aggregate and doesn't necessarily mean in the individual. It doesn't mean that all patients with a bad genetic abnormality do worse than all patients that don't have a genetic abnormality. There's a lot of variability, and it becomes very important when you're thinking about averages, whether it's average time without myeloma, average survival. Their average, half do better, half do worse. And so it's important, I think, particularly for physicians, to just have a general understanding of what we think the biology will be. But you get fooled a lot where patients where you think the outcome won't be spectacular do remarkably, remarkably well. And then there are patients where you really expect a very favorable outcome, and sometimes that can be disappointing. So you just don't want to put overemphasis that any specific abnormality means something. I mean, the reality is that the average American is taller than the average Japanese. And so on average, it's pretty likely, but you wouldn't want to bet your house that the next person you run into when you're in Tokyo is going to be shorter than you, because the consequences would be profound. Again, it's just about averages, and just as we talk about prognosis, to just kind of gel that.
Could you, in terms of chromosomal abnormalities, the three terms that we hear all the time are translocations, additions, and deletions. Can you explain what that means and perhaps give a couple of examples?
You have to go all the way back to high school, I guess. When you remember, you look at those pictures of the chromosomes, and they're all lined up, and they have partners 1, 2, 3, 4. They have corresponding duplicates, and then there's an X and a Y. Make sense? Remember that? So what we're talking about here is in the cancer that some of those can get mixed up. So a translocation is when a piece of one chromosome comes off and tags onto another piece. And what that does, it takes the gene from, let's say, chromosome 11, that is at the place that there was a breakage, and it tags it onto, let's say, chromosome 14. So those two genes that don't belong together get shoved together, and it makes a new gene. So that's what a translocation is. So commonly, the most common one we would mention is 1114. Many of these involve chromosome 14 in myeloma. So 11 and 14, 4 and 14, which is thought of as being worse, 14 and 16, again thought of as being worse. So those are what the translocations are. You can also have missing portions or entirities of a chromosome, which obviously will get rid of a whole bunch of genes. Or you can have extra versions of chromosomes, additions of the entire or portions of the chromosome, which will give you a whole extra bunch of genes that you shouldn't have.
The other issue that has changed, we're going to get to we'll get to questions after, unless it's got to be asked. Okay. One of the other relatively newer concepts in myeloma, at least in the time that I've been involved, is that we can now differentiate between standard risk and high risk. Can you explain what is standard risk myeloma as compared to high risk myeloma, and also a little bit about why we can't define high risk in a simple way.
When we talk about cancer staging, really that's just a way of understanding what we interpret as risk for patients. So when we talk about breast cancer, stage 1, 2, 3, 4, you intuitively know you'd rather be a 1. And colon cancer, 1, 2, 3, 4, you'd rather be a 1. So staging is really an attempt, in simple terms, to try and understand risk. And so the current staging system is called the Revised International Staging System. And I think just like knowing your protein and your protein levels, you ought to know what stage you are. And that's determined by some simple blood tests. One of them is the beta-2 microglobulin. That's a test that every multiple myeloma patient has to have prior to the initiation of treatment. And if you don't get that, then that's a substandard. And the blood albumin level, which everybody has automatically as part of their evaluation. And that's combined with the exact genetics that Dr. Patel talked about, and that integrates to try and get people into a stage 1, stage 2, stage 3. And because when you do that, it is predictive of outcomes, again, with very large numbers of patients, in each group actually thousands. And so that those tests are valuable in understanding, and so they predict risk. The underlying biology is not well understood, so why people who have a beta-2 microglobulin don't do as well, I don't know, do those patients have more myeloma? And why the blood albumin, is that some reflection of are they chronically sick? And why this 414 and 1114 and other changes, why it leads to shorter times on average without myeloma or poorer outcomes with treatment remains very, very unclear. Are we getting close to what you're asking?
I forgot the original question.
Standard and high risk.
Go ahead.
Standard and high risk. What do patients need to understand about the differences between standard and high risk?
I think these are the major things. I think the thing that Dr. Gertz keeps highlighting that's really important is these are things that have been developed by looking at hundreds and hundreds of people. So it's really important to know them. It's a standard of care to do these tests. I think what I also want to emphasize on an individual level, we're not really too sure how to modify things. Yeah.
There are clinical trials, so we're talking about research, medical research, not standard care, that cooperative cancer groups in the United States have attempted in an effort to look at the impact. And so the treatments in experimental research trials have been different. So for standard risk myeloma, the national US trial that just recently closed was a comparative of VRD, Velcade, Revlimid, Dex, bortezomib, lenalidomide, Dex, with KRD, carfilzomib, Revlimid, Dex. Carfilzomib is Kyprolis, Revlimid, Dex. For standard risk and for high risk, the monoclonal antibody daratumumab, its trade name is Darzalex, was used to see in that one-arm study whether adding that would be beneficial for high-risk patients. But day in and day out in the clinic today, and what I see in my referral practice is that literally 90% of the patients with myeloma are getting VRD induction, Velcade, Revlimid, dexamethasone, and a few patients are getting Velcade Cytoxin, cyclophosphamide, dexamethasone, usually if their kidneys are not well, or they start treatment in the hospital because it's very difficult to acquire Revlimid on a hospitalized patient, and they'll start on that. But that's 98% of our patient population right now, independent of their risk stratification. So for many patients and many laboratories, it takes a week to two to get the results of the genetics, and some people can't wait for that to come. So you start the treatment while you're waiting for the genetic information, but it's not driving the decision regarding initiating therapy or which therapy you select.
I just have, how many of you know what those of you who are patients know what your chromosomal abnormalities are? Okay. So for those who don't, what's the important question they should be asking of their physicians?
What is it? Yeah. Yeah, exactly. So exactly what we talked about, knowing the stage, and part of knowing the stage nowadays is making sure that test, the chromosomal test, is done at diagnosis.
I tell people all the time that when you're a myeloma patient, knowing your chromosomal abnormality issues is as important for the average person to know their blood type. Is that going too far?
No, you first. I have a question
Okay.
for you.
I was going to say, I don't know my blood type, so yeah, I guess it's more important.
A positive. So here's the question that in practice. So patients referred to you for myeloma management. The home doctor did a bone marrow, got the plasma cell count. It was done a week ago. FISH wasn't done. Are you repeating the bone marrow?
Oh, that's a really good question. So there's a lot more than having the information that goes into that. Who wants to have a second bone marrow? Who will punch their doctor in the face if he suggests it? Yeah. So I think that from just the human standpoint is oftentimes what stops me telling people, hey, we should do a second bone marrow. We do see this a lot, though. This is a very common thing. Or I have to unfortunately tell you the other thing that I do see a lot is the test was sent and it never got looked at or seen, and it's on a separate piece of paper somewhere that we can't even, yeah, you don't get, or you can't even get if you try to. But yeah, I think because it's not driving that initial treatment decision, I find it very hard to push people to get a second bone marrow biopsy literally a week or two later.
And I would agree with that. In my practice, if you're going on a clinical trial, then you're getting a bone marrow. But if you're there for an opinion and to start therapy and you had a bone marrow a week ago and I know the diagnosis and everything's ready to go, I don't repeat the bone marrow, but I would argue that it really was an omission of care the first go-round when you're bothering to stick the needle in, not to get the genetics. Either means the diagnosis was a surprise, they just didn't expect it. I see that as a problem as well. Or for some reasons they elected not to do it, and I don't think that would meet the standard of care for a newly diagnosed patient.